Yeah, I think it's a really good question. I think that is the dilemma that's going to face the healthcare system in the next period. We've had the last 10 years getting well more than inflation, 7% on average, more than inflation into our system. We've improved the system, but we are going to now face a period where we're going to have basically probably about the same amount of money, but we're going to have to absorb the pressures that come from increasing demand due to an ageing population, new medical technologies, and new drugs. There aren't really many options for dealing with that. Our traditional way of being able to deal with this in the NHS would have been in some way to restrict capacity, to cut our costs. But we've made lots of promises, and the public expect us to deliver on those promises. So, access to care, short waiting lists, low waiting times in emergency departments, access to new cancer drugs, whatever it is. If we try and cut those off and restrict it, we're not going to do well there at all. Really, the only place we can go is to look for those things where we can improve our quality, but also at the same time improve our efficiency. And there are lots and lots of these opportunities in the system. We've tended to work over the last 60 years or so, the history of the NHS, on the basis of a sort of paradigm that said that the way you got quality was to invest more. So when I was running a hospital, anytime anybody wanted to improve anything, get a better quality, they'd come along with a shopping list of more doctors, more nurses there.
Yeah, and this is not the case anymore?
Well, I think it still is. It still sort of is partly in our psyche that's how we think. My feeling is that if we're going to survive this next period, the greatest opportunity we've got is to shift that paradigm to one where we can see that care is only considered to be high quality if it's also efficient. And that sounds like it could just be rhetoric, but if we look at how we perform in the healthcare system, the system is absolutely riddled with variations in how we do things, which means that the quality is lower and the efficiency is lower. I mean, for instance, if we just looked at something like day case surgery, we know how to do lots of procedures by day cases. It's good for patients because they don't have to be in hospital for too long, and it's efficient for the system because we don't have to look after them for longer than we need to. And yet we've got basically a twofold variation across the system. Some hospitals are very good at doing some procedures by day cases, others do none at all
So it's by changing those practices also at a very micro level that we can make real improvement.
Yeah, and I think that's a good point here. This is at a micro level. It's decisions that are made on a daily basis by practitioners, deciding whether they're going to admit, refer, prescribe, discharge somebody from the hospital, and it's their individual practices that need to change, of course prompted by the system in terms of the way we put incentives into the system and how they're led.
So you believe that changing those incentives and trying to change those practices and also trying to communicate what is good practice, and those can really make a difference?
Yeah, I think they can. I mean, I think it's what I'd sort of talk about is the classic sort of change equation. We need to give people sufficient push to move, meaning we need to help them see that their practice is sufficiently different or inefficient or bad for their patients, so that they've got the incentive to change, and that means giving visibility to the differences in the way we provide care. And then we need to give them the pull, which is showing them how to do things better with best practice examples, connecting them up with colleagues. Because in all I'm talking about here in terms of being able to perform better, we're not talking about setting new frontiers of efficiency. All we're talking about doing is being able to move to those that we already know how to do. Somewhere in the system, somebody already does it as efficiently as I'm talking about, and what we need to do is understand how to do that.
So the challenge is not to reinvent ourselves, is really to try and understand how things are perhaps currently done in a good way, and trying to adopt those practices. So it's more like a diffusion of those practices.
Absolutely, and it's the diffusion of those practices across the system at a sort of micro level, and this is the real challenge in this. There isn't a quick fix. I think we sometimes want to look for a quick fix, so we want to do a clinical reconfiguration, close hospitals, move services, amalgamate things, or rationalise our physical estate, close hospitals and open polyclinics or whatever it would be. or if all else fails, we want to do a structural reorganisation of our management as a quick fix. But this isn't going to be a quick fix, and there's no silver bullet for it. What we've got to do is work on each individual service. So it'll be the orthopaedic service in an individual hospital that needs to look at how it can transform its care for the benefit of its patients and the benefit of the system by looking at what's being done in a better way elsewhere. And unless you're already up at the top of this, there's always somebody else in the NHS in roughly the same context as you doing it better than you're already doing it.